be HMP pathway or glycolytic pathway and other enzymes which are there in the RBC. So the defect can arise either in the membrane or in the hemoglobin or in the enzymatic system. So we start first, that is inherited. Usually the intrinsic or intracorpuscular defect are inherited nature except certain exceptions. So first is membrane disorders. Out of these, there are list of causes, that is spherocytosis, elliptocytosis, acanthocytosis. Now, as the name suggests, elliptical cells, stomatocytosis, acanthocytes are the cells which have spiculated surface, irregular, very few spicules seen on the surface. So these are, out of these, the commonest is the hereditary spherocytosis. Then qualitative structural abnormality of globin synthesis, and that is the sickle cell disease. Then you have defect in the enzymes. The commonest defect is the glucose 6-phosphate dehydrogenase deficiency or G6PD deficiency. Then you can have pyruvate kinase deficiency and other. There is a list of enzymes which can fall in this category. The second is the acquired. Now, this is the only exception, that is the PNH, in which there is a membrane defect, but it is an acquired condition. So, if I summarize the intracorpuscular defect because of the membrane, commonest is the hereditary spherocytosis. The hemoglobin, the globin chain defect can be either quantitative or qualitative. Then the defect can be the red cell enzyme. The commonest is the G6PD. Now, out of these, which are the red signs, are the one which present with intravascular hemolysis. For example, in G6PD, otherwise there is not much anemia, but they have, if there is exposed to certain drugs, for example, dapsone or anti-malarial drugs, they can cause sudden acute intravascular hemolysis. Similarly, in sickle cell, usually it is extravascular, but it can cause intravascular hemolysis also. So just remember, all red things are because of intravascular hemolysis. Then the extrinsic cause or extracorpuscular abnormalities. The first is the mechanical trauma to RBCs. One is the prosthetic cardiac valves. The others are the part of the microangiopathic hemolytic anemia. Like in the small vessels, there is a small thrombi are formed in the capillaries and these small vessels. And when the red cells pass through these vessels, this leads to mechanical trauma to the RBCs. So this is the causes are the DIC, then thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. All these lead to intravascular hemolysis. There are other causes also like physical agents, chemicals, infections like malaria and clostridial infection, which can lead to intravascular hemolysis. Then very important group is the antibody mediated group, which is allo antibody or auto antibodies. Allo antibodies, the commonest is the mismatched transfusion reactions, or it can be because of the erythroblastosis fetalis, which we all know is because of the ABO or RH incompatibility between the mother and the fetus. The ABO is more common but less severe, RH is more severe but less common. Now, autoimmune hemolytic anemia, as the name suggests, the antibodies are directed against the self-RBCs. Now, the antibodies can be warm antibodies. They are usually IgG type. They are also known as incomplete antibody and they react at around 37 degrees centigrade. The cold agglutinins are the one which are usually IgM type and they can cause, although they cause usually extravascular hemolysis, but they can cause intravascular hemolysis also. Then paroxysmal cold hemoglobinuria or PCH, which is again IgG type, but it causes intravascular hemolysis. Then again, the red cells are normally destroyed in the spleen. So if the splenic function is increased, for example, is a splenomegaly, then it can lead to hypersplenism. And there are other causes of anemia. Now, in the extrinsic causes, the commonest is, which we have seen is, which we are going to see today, is the microangiopathic hemolytic anemia, the autoimmune hemolytic anemias, and the rare causes can be like spur cell anemia and liver disease and a snake venom, which can cause hemolytic anemia. So this is the first part which we have done, that is the increased destruction of RBCs. Now we come to the second part, because in the definition I told you that both the things should be there. One is increased destruction and second is the increased erythropoiesis. Now, how do you know the erythropoiesis is increased in the marrow? You can do bone marrow examination, but bone marrow examination is not indicated for hemolytic anemias. You can have simple tests, like you can see here, these are the reticulocytes which are of the different maturation, and you can get the percentage of the reticulocyte is 0.5 to 1.5%. But remember one thing, you are counting the RBC, the retic count in the RBCs. Here are the RBCs. Now, if the patient is anemic, the number of RBCs will be less per field. So you will have a spuriously high reticulocyte count. That is why you do the corrected retic count. You multiply it by the patient hematocrit divided by the normal hematocrit for that age. Or you can get the absolute retic count. Now, most of the analyzers in which retic count is done, we get the percentage and we get the absolute count. The absolute count is around 25 to 75. In some books, it is 25 to 100 into 10 to the power 9 per liter. So anything which is above 100 means the marrow is adequately responding to the destruction of red cells. The polychromatophils and the fine basophilic stipling, which you can get in the peripheral smear, the macrocytosis. See, normally the reticulocyte is reticulocytes are slightly larger in size. They are 20% larger than the normal red cell. So that is why they appear larger, the macrocytosis. Second thing is, when there is a excessive erythropoiesis, more premature cells are released, and the more premature retic is further larger in size. The third point is, when there is an excessive erythropoiesis, there are skip cell divisions. And you know, when there is a division, with each division, the cell size is decreased. So when there are skip divisions, that lead to increase in the size of the cells. Then apart from that, you can have neutrophilic leukocytosis or thrombocytosis may accompany hemolytic anemia, or erythroid hypoplasia in the bone marrow, which is usually not indicated in the diagnosis of hemolytic anemia unless you suspect aplastic crisis in these patients. So this is the next thing is, after getting the CBC findings, the most important test which we, with the era of automation, we shouldn't forget the gold standard, that is the peripheral smear examination. Because your further line of investigation will depend what you are seeing on the peripheral smear. Now we take the first smear. You can see these are the normal red cells which have 1/3 pallor. This cell is larger in size, totally hemoglobinized. So this is a polychromatophil, slightly bluish hue. But what are these cells? These cells are smaller in size, they are dense, there is no central pallor. So these are the spherocytes or microspherocytes, you can say, they are seen. So your further line of investigation will depend upon the presence of spherocytes in the peripheral smear. So you will further investigate accordingly. Then this is the second is the all cells are elliptical in shape. So this is hereditary elliptocytosis. Now you can see here what are these cells, as if something is removed from here. Like this also, a bite is taken. So that is typically seen in cases of G6PD deficiency. This next is, you can see elongated, fully hemoglobinized, dense cells. These are all boat-shaped cell or elongated sickle-shaped cells in the peripheral smear. So you will further investigate according to the presence of these sickle cells. Now this cell, see that they are all fragmented cells. So I have told you, when these red cells pass through small vessels which have multiple thrombi, that leads to mechanical injury and fragmentation of the red cells. So if you find these fragmented red cells which are known as schistocytes in the peripheral blood, you will investigate accordingly. Now this slide shows leptocytes, target cells, microcytic hypochromic cells, occasionally spherocyte you can see here, and in the other fields you can see these in RBCs or erythroblast, and there is a marked anisopoikilocytosis. So this is typically seen in thalassemia. major. So depending upon the further investigation of these patients, you have to look carefully. A good peripheral smear is must. Now, so if I summarize, you have to know how to suspect hemolytic anemia, then you will see what are the causes, and accordingly you will investigate. So we will go through the cases and we'll see how will we apply this knowledge there. So this is the case 1. 6-year-old female presented with pallor, jaundice and splenomegaly. Now this is a classical triad of hemolytic anemia within a child. So that is possibly a inherited disorders of hemolytic anemia. If you see the hemogram, the patient is severely anemic. What is important here is the red cell distribution width. Now this red cell distribution width gives the indication of the variation in the size of the cells in isocytosis. So here normally is around 11 to 14%, but it is quite high. Another thing is the MCHC, which is 35.3 gram per deciliter, and normally it is the upper limit is 35. So there are very few anemias which present with high MCHC, which we'll read further. So, and the corrected retic is also high, so it shows that there is triad of pallor, jaundice and splenomegaly. There is corrected retic is high. That means it is possibly a child with an inherited hemolytic anemia and the marrow is responding adequately. Now, the second most important test is your peripheral smear examination. Now see, in the peripheral smear, what we see is the variation in the size of the cells. You can see here, there is marked anisocytosis, and what are these dense cells are the spherocytes. Now these are the cells which appear dense and they are of almost same size, and these are the normal cells, and there are few cells which are larger, they are possibly the polychromatophils. So you see spherocytes in the peripheral blood. You should know what are the causes of spherocytes, and accordingly you have to investigate. So what are the causes of spherocytosis? Remember one thing, any cause of cell injury, if there is some membrane loss, the ratio of surface to volume is decreased, and that is why the cell, they assume a spherical shape, any cause of cell injury. So we start first, the two important causes of spherocytes are the hereditary spherocytosis and autoimmune hemolytic anemia. What happens in the spherocytosis? There is a defect in the cell membrane, so membrane is not stable, and that leads to loss of membrane and it becomes spherical. In autoimmune hemolytic anemia, especially the warm type of autoimmune hemolytic anemia, the IgG, they stuck on the red cell, they bind with the red cell, but they cannot agglutinate the red cell. So through the FC receptor, they go into the spleen, and the macrophages, they just remove that part. So when the part of the membrane is removed, they become spherical in shape. So these are the two important causes of spherocytosis. The others can be ABO incompatibility and G6PD deficiency, which we'll see in the next case. Then the other causes, like we have a case of Wilson's disease where the copper is increased and that leads to membrane injury. Similarly, the snake bite and the Clostridium toxins, they cause release of enzymes which causes damage to the phospholipid of the cell membrane. So all these in which there is a membrane loss, there is a decreased surface to volume ratio, becomes spherical in shape. So in this patient, the mother of the patient, the hemogram shows the similar finding, except it is mildly anemic, but MCHC is raised and the RDW is mildly raised and the retic count is high. So I think what further tests are required? The two important causes I have told you. One is the spherocytosis, hereditary, and another is the autoimmune hemolytic anemia. Now in this, the family history is there. The mother is showing the similar picture, so it fits into the hereditary cause, and the direct antiglobulin test or Coombs test is done, which is negative in both this patient and the mother. So next test is done. This is the osmotic fragility test. Now basic concept of osmotic fragility is that this is the rising concentration of saline and this is the percentage of hemolysis. If it's a biconcave disc, the more water can enter into the cell and it will not rupture. But if it says spherocytes, it's already become spherical. So a less amount of water can enter into the cell. So you can see here the hemolysis start at this concentration. While in a normal person, the hemolysis start at this concentration. So when there is a spherocytosis, there is a shift to the right and the 50% lysis occurs at much earlier stage as compared to normal. Plus, you can see these are the tail of fragile cells or spherocytes in the graph. So when you report osmotic fragility, you write the mean corpuscular fragility, what concentration of the saline with the presence of the tail of fragile cells. Now, what are these tail of fragile cells? These are the spherocytes which are there in the circulation. Remember one thing, the spherocytes which are there in the circulation, if they are very few, then your osmotic fragility test will be normal. So what you do, you incubate this blood for 37 degrees centigrade for 24 hours and next day you perform the osmotic fragility test and you find, because these cells, they lose the membrane much earlier, so this tail becomes prominent. So if anybody asks you which is the best test, it is the incubated osmotic fragility test, not the osmotic fragility test, right? So diagnosis is hereditary spherocytosis. Now, a brief about this, because the next lecture is on your membrane defect. So I just briefly tell you that the most common genetic abnormality is the ankyrin. These are the proteins which are horizontally arranged. These are the ones which are vertically integrated or binding it to this is the phospholipid layer of the RBC membrane. So this is the skeleton framework. So you find the spectrin are these alpha and beta, and this is ankyrin, this is band 3, this is protein 4.2. So although ankyrin is common genetic abnormality, but with the biochemical abnormality is the deficiency of the two. Now why is it happening? Because the ankyrin, it binds spectrin to the vertically integrate to the membrane. If ankyrin is not there, even these spectrin bands, they are destabilized and they are destroyed much earlier. So that is why biochemically they have deficiency of ankyrin and spectrin both. This disease is autosomal dominant in most of the cases, but about 1/4 cases it can be de novo or non-dominant. The other changes which you should look in the peripheral smear is that the spherocytes, they are very fairly uniform in size and density as compared to autoimmune hemolytic anemia. In band 3 deficiency, they have a pincer-shaped or the mushroom-shaped morphology. Then in beta spectrin defect, you can have acanthocyte. You can see the projections here with the dense loss of central pallor, dense cells with some fine projections. So these are the spherocytic acanthocytes. So how to judge severity of hereditary spherocytosis? There are parameters based on hemoglobin, retic, bilirubin, and osmotic fragility and presence of spherocyte. This just want to show you that even in the trait, the fresh blood osmotic fragility is normal, but the incubated one is slightly increased. So this is more ideal to say incubated osmotic fragility rather than a fresh blood osmotic fragility. The other tests which can be done, they will be covered in your next lecture, but briefly I just mentioned it's the EMA binding test or eosin 5 maleimide dye. Now this binds with the band 3 protein on the red cell membrane. So you see the fluorescence by flow cytometry, and if you see if mean fluorescence intensity, this is the control red cells and this is the spherocytic cells. So it becomes less. So how much it is less, you can calculate with the comparison with the controls. There are various other tests also, like acidified glycerol lysis test. This test gives you the time in which 50% hemolysis occurs. So that is again, normally it takes about half an hour, say, for 50% hemolysis, but in a spherocyte, this will take 2 to 3 minutes for 50% lysis. The confirmatory test, this is the flow cytometric osmotic fragility test. Then this is the one which is confirmatory SDS page electrophoresis, but like these are the bands which are seen, but this is not available routinely, and we will have the deficiency of enchirin, but this is only the research lab they are available. So generally, this is the now golden test by which you can do the pick up the HS or spherocytic cells, and this will also differentiate it from the autoimmune hemolytic anemia, because the autoimmune hemolytic anemia, the membrane is content is normal. So there are certain newer parameters also which we can see in the automated analyzers for spherocytosis. This is basically for the third year postgraduates, if they can remember. Now this is, I have already told you, high MCHC with high RDW, it's a very good test to pick up spherocytes. The other test is the mean reticulocyte volume. Now, I've told you the retic is larger than the normal red cell. But what happens in spherocytosis, the loss of membrane starts at the time of formation of retic. So when the reticulocytes are formed, their size is not so large. So if they're less than 96.7 femtoliter, this is suggestive of spherocytosis, and that will help in differentiating it from the autoimmune hemolytic anemia or G6PD deficiency. Then the other parameters, like they can be dense erythrocyte if they are more than 4% with high MCHC, or this is a newer parameters. Like in this, what happens, the cells are passed in a hypotonic solution, so they become spherical. And when the cells become spherical, they become larger in size in a normal person. So MSCV minus MCV will be more than 0, but in spherocytes, this does not happen. So if it is less than 0, the difference, then it is highly suggestive of spherocytes in the blood. So these are the newer parameters which can be picked up. They are present some in Advia, some in Coulter, some in Sysmex. So there are various different types of equipment in which we can see these parameters. Now we come to the second case. Now this second case, yes.
There is one question pertaining to spherocytes, so I thought I'd ask you here.
Yes,
Dr. Razan asks, can we say that spherocytes are pathognomonic for extravascular hemolysis?
Spherocytes is usually seen in extravascular hemolysis because part of the membrane is removed by the splenic macrophages usually, and a part is removed, so there is some membrane loss, and if it's a large membrane loss, it can lead to complete lysis of the red cell. But if it is small membrane loss, they assume there's a decrease in the surface to volume ratio and they become spherical. So yes, seen in extravascular hemolysis.
Right. And there was another question on retic count. Lucky asks. Yes, ma'am. Retic count, is it done?
The oil, yes. You have to do in oil.
And how do you differentiate between the muck or the stain deposits and the reticulocyte granules on a...
If you change the focus, see, reticulocyte, the definition says you have to have 2 dots to make it a retic. That's the most mature form. But if you see the reticulum, if you change the focus, you can easily differentiate whether it's a deposit on the cell or it is within the cell.
Okay.
Anything else, or should I go to the next?
You can go to the next case, ma'am. Okay, there is another question.
Next case is the 1.5-year-old male child who presented with hepatosplenomegaly and pallor with fever, cough and vomiting, and the clinical diagnosis was suspected of hemolytic anemia. Now this is the CBC finding. Patient is severely anemic. The retic count is high, so it is marrow is adequately responding. This is the peripheral smear findings. Now you can see there are cells as if a bite is taken from these, which I have shown you earlier also, here also. So these are the typically seen in this patient. Bilirubin is almost normal. Other tests like Coombs test is negative, OFT is negative, sickling is negative, and HPLC of both parents and the child was negative. So the diagnosis is they did the glucose 6-phosphate dehydrogenase assay, and they found that it is decreased. Now this is what is the supravital preparation which we do for retic count also. So it's a simple test. We can see here is the inclusion or Heinz body, which are characteristically seen in the G6PD deficiency. So seeing those bite cells like morphology, you can see a few spherocytes also, and if you do simple retic preparation, you can make out these Heinz body and you can suggest the diagnosis. You can do the assay for G6PD. The diagnosis was confirmed at G6PD deficiency anemia. Now, brief about G6PD is that G6PD, it converts NADP to NADP. It's a dehydrogenase. So it is removing hydrogen from here and it is adding to NADPH. Now, this NADPH converts oxidized glutathione to reduced form, and this reduced form neutralizes hydrogen peroxide to water. That is how it prevents the injury to the cell. So when there is a no G6PD, there is accumulation of H2O2 which causes damage to the RBC. It can cause complete damage to the cell membrane and can cause intravascular hemolysis. But if it's denatured and precipitated globin chains, they precipitate as Heinz body and they are removed by this spleen. So it appears as if it's a bite is taken or taken from a spherocyte also. But here it is actually the hemoglobin which is denatured and it is retracted from the circle. This is known as blister cell. So now they say that's not the bite, it is not because of the bite by the splenic macrophages, it is because of the denatured hemoglobin. That is why it is retracted and gives a blister appearance. So it is removed by the splenic macrophages and it leads to extravascular hemolysis. Then this is just to show that it's an X-linked recessive disorder, and this is the female heterozygous, means one chromosome is normal, one is abnormal, and this is a very wide range. Why? Because of the Lyon hypothesis. As the Lyon hypothesis says that the inactivation of the X chromosome, which can occur very early during the embryogenesis or the late part. So it's a very wide range of G6PD of the normal, that is the 30 to 80%. So it is difficult to pick a female heterozygous, but if it's less than 30%, it is clear-cut deficiency. If it is more than 80%, it is normal. G6PD is more prevalent in malaria endemic area. Why? Because the parasite, it enters into the cell, red cell, and it leads to damage. Because G6PD is not there, the cell is damaged and cell is lysed before the parasite complete its life cycle. So that is why it is more common in malaria endemic area. There are various variants of G6PD. I am not going into the detail of these because this will be covered, I think, in your next lecture. But the two variants which I want to emphasize is, one is then, which is seen in India also, is the G6PD A-. The important thing to remember is, when the cell is formed, the G6PD activity is normal. But as the cell matures, the half-life of the enzyme activity is only 13 days, while normal is 62 days. That means as the cell matures, it will rapidly decrease in the G6PD A- variant. While in G6PD Mediterranean, it's all the cells which are less and the enzyme activity is less than a day. So it is causing severe hemolysis as compared to G6PD A-. And this is the if one asks, did you measure the G6PD activity at the time of the attack? You should not, because the retic count is high and the retic is usually having normal activity. So you may get the falsely negative results in such cases. So it's better when the attack of hemolysis is subsided, then you measure the retic count. The various other tests which are done for the G6PD deficiency, the brief, I'll just tell you that this is an oxidant which converts oxyhemoglobin to methemoglobin. Remember, iron in HbO2 is in the ferrous state. When it is converted into ferric state, it's called methemoglobin and it is brown in color. And then you again add methylene blue, it will again be reduced to HbO2 if G6PD is present. If G6PD is absent, this will not be reduced and remains the brown color. So you can see this is the brown color, this is the red color. So you can pick up, it's a semi-quantitative or a qualitative test which is routinely done in our lab also. Another is a simple, reliable screening test is this fluorescent spot test. Now, if G6PD is present, NADP will be converted to NADPH, and this is fluorescent under the UV light. If it is not present, then there will be no fluorescence under UV light. Now, G6PD can also be done by the flow cytometry also, or you can do NADPH assay by kinetic method by the spectrophotometer. So again, I think this will be covered in your next lecture. So we come to the next case. Any question you want to ask? So, yes.
There is another question on the retic count again.
Yes,
So,
yes.
Dr. Shruti asks, why is the corrected retic count required when you are still counting individual RBCs and taking reticulocyte?
If you count in a severe anemic patient, what you find in the smear, there will be mature RBC, will be very few. Suppose there are 10 RBCs and you are getting 4 retic in the 10 total RBC, and in a normal person in 100 you are getting 4. So that the anemic patient will give a high value of retic count, but actually speaking, for the whole blood the count is less. So you have to do correction for the RBC count. That is why they say the absolute retic count is important when you multiply with the RBC count.
Right, ma'am. And there is another question unrelated to hemolysis. Dr. Shruti asks, what is the reference material we can use to know the normal RBC range for preterm newborns and term newborns, if there are any?
Reference material?
Or any article which gives us the values of these?
The values can be vary in the different populations also. But if you see the Winthrop, the older Winthrop gives, in the end, the appendix give all the normal values of all the parameters, the coagulation factors, everything for the month and the day wise. Similarly, the DACY gives all the parameters of the 6-month age at the birth, 6 months, 3 to 6 months, and more than 6 months to 1 year. All the tables are given. But for Indian, I don't exactly remember now for any data set, but maybe it must be there.
Right. And there was a question earlier during the class. Is it possible to differentiate between DIC and
yes, for
TTP on peripheral smear?
On peripheral smear, you can't differentiate because TTP, HUS, and DIC all will have schistocytes with thrombocytopenia. So you can't. You have to do other tests.
So those are the questions for now. You can go ahead.
So we come to the case 3. Now this is the 2.5-year-old child who presented with the hepatosplenomegaly and pallor, and the characteristic PS findings were microcytes, leptocytes, target cells, and many elongated sickle-shaped cells. So the retic count is high. So we thought of a sickle cell anemia, and that time actually this is about 18 years back. We don't have anything HPLC in our department, so we did alkali denaturation by for HPF, and it was raised. So we thought of it can be sickle thal. This is the blood picture. This is the blood picture during the follow-up of the patient, not at the time of presentation, but you can see a lot of target cells. You can see here the target cells are actually the bell-shaped cell. So when you see from the top, you will see a central hemoglobin, the clear area, and then a hemoglobinized area. Then you can see these dark staining sickle-shaped cells. There is a nucleated red cells. Can you see this dot? These are the Howard-Jolly bodies, which are seen more with the sickle cell anemia because of the infarct in the spleen leading to decreased splenic function. So this is the sickling test which we performed with 1% sodium metabisulfite, and it was positive. So we thought possibly it's a sickle beta thalassemia because of the microcytic hypochromic picture and sickle with raised HPF. Now, when we got HPLC, we did the HPLC and it was found to have sickle D. So this patient was having 2 peaks. One is in the sickle area and another is in the D Punjab. The father HPLC actually shows microcytic hypochromic with high RBC count, suggests to a beta thal trait, but also has a sickle peak of 24%. So it is HPS beta plus was suggested. The mother was again anemic, microcytic hypochromic, and has peak in the D Punjab area. So possibly the child got D Punjab from the mother and sickle from the father, and the diagnosis was made as doubly heterozygous for HPS, HPD Punjab was suggested. Now, the same patient in the last follow-up in the month of December presented with fever and pneumonia. Now, what you find here is patient is severely anemic, right? Now what you find here is MCV is markedly raised. MCH is also raised, but what about MCHC? It is very high. So again, this is the anemia where MCHC is high. Now above, say 40, it is this MCHC is not actually at this level. Hemoglobin is not soluble in the red cell. So this is artifactually or erroneously high. And the reason behind this is, you can see here, there is a lot of clumping of or agglutination of RBCs. You can see few sickle if you can make out, but here also is sickle, but they are all agglutinated and it is difficult to see the blood picture. So when you find this type of picture, then you should think of cold agglutinin disease. It's in the December month, it's a cold weather, and this parameter is very suggestive because what is happening? This whole bunch of cell is counted as one cell. So the RBC count is erroneously low. The hematocrit is also erroneously low, and when you calculate MCHC, this becomes falsely high. So that gives a clue for the diagnosis of CAD. So what are the causes of high MCHC? It can happen in hereditary spherocytosis. It can happen in sickle cell anemia because of some dehydration of the cell. Then it is seen in the cold agglutinin disease. So you should look grossly the sample. Can you see here? This agglutinates can be seen sticking to the vacutainer. So after we warm the sample at 37 degrees centigrade, the clumps disappeared and you can see the change in the parameters. The MCHC from 45 has come down to 33.6 gram per deciliter. So that again gives a diagnosis of cold agglutinin disease. The DCT was done. The IgG was negative. IgG is usually positive in warm antibodies. The C3d is positive. And these patients' serum showed negative reaction with I antigen negative cells, but positive with I positive red cells. Now, what are these cells? Normally, small I and capital I antigens are present on the red cell. Small I is present on the neonates or up to say 12 months or 18 months, and then it changes into capital I in the adult. So most of the adult red cells are I positive. So these antibodies are usually directed against the capital I antigen, and the titer is important, which is about 1:64. So the diagnosis is cold agglutinin disease, query post-infection. So brief about autoimmune hemolytic anemia. The important thing is the presence of autoantibodies plus red cell destruction is must. It's not only the presence of autoantibodies, there should be the evidence of red cell destruction. And this, I have already enumerated the causes of autoimmune hemolytic anemia. They can be primary or idiopathic or secondary to underlying cause. Now, how these cells are destroyed by the IgM antibody. This is the pentameric structure. See, that is a difference from IgG. The distance between the two arms is very less in IgG, so they cannot agglutinate the red cells. But this is pentameric, can agglutinate the red cells. But still, the extravascular hemolysis is common in this IgM-mediated red cell destruction. Why? You know, there are certain proteins which are present on the surface of the red cell. Now, these proteins, they protect from the complement-mediated destruction of RBC, and these are known as CD55 and 59, which are abnormal in PNH. So normally they protect the red cells by the complement from the complement destruction. So what happens when the IgM antibody in the cooler area, it binds to the red cell, it activates the complement, and once it reaches the central part of the body, the IgM detach from itself, but the C3b component remain deposited on the surface of the red cell. So when these cells, they go into the circulation, they reach the liver, the macrophages in the liver have receptor for C3b and they are removed in the liver. So primarily they are removed in the liver and causes extravascular hemolysis. But yes, if the titer is very high, if the thermal amplitude is very wide, then they can overcome these regulatory proteins and can cause intravascular hemolysis. But usually the secondary causes lead to extravascular hemolysis in cold agglutinin disease. So, cold Cold agglutinin disease, recently, I just want to mention that it is divided into two. A recent WHO classification has come, which included CAD with the pre-malignant conditions, because it is associated with indolent lymphoproliferative disorder in the bone marrow in most of the cases. And rest of the cold agglutinins associated with other diseases is known as cold agglutinin syndrome. So this is a recent development which you should know. Then the criteria is the same, that they are monoclonal antibodies produced by clonal B cells, IgM type with anti-I specificity. Titer should be more than 64 and 4 degrees centigrade. Usually, if they are more than 1000 titer, then they can cause intravascular hemolysis. But in a low titer, generally they don't cause intravascular hemolysis. Important thing in this is how to collect the sample, because already the samples show agglutination, so it is very difficult to do blood grouping or the testing for the workup for these patients. So you should collect all your samples at 37 degrees centigrade. You should warm your syringes or vacutainers, and all the things should be done in the 37 degrees centigrade till the separation occurs. Now we come to the fourth case, that is the 5-year-old boy who presented with seizures, abdominal pain, vomiting and fever. There is hepatosplenomegaly, but CN is normal. There is no suggestion of meningitis. The patient diagnosis was query entry, query malaria, query disseminated TB was made. The patient was anemic. The retic count is normal, within normal range, but maybe less for correction. But rest of the workup for fever and all, it's almost negative. Did not respond to intravenous antibiotics, but developed gross hematuria and facial puffiness. At that time, the patient hemoglobin is fallen to 5.2, retic count is increased, TCT, ICT was negative. Now again, the very important test, that is a peripheral smear examination. So what you find here is, can you see here, this is a triangular kite-like, this is again a triangular, this is spiculated two ends. So these are all fragmented red cells. Right? So this is a small spherocyte, but otherwise most of the cells are fragmented or schistocytes. So when you see schistocytes, the all plus there is a renal involvement, you should think of HUS or TTP or TIC. Now this patient, these are the causes of schistocytes indicative of microangiopathic hemolytic anemia. Now a word about schistocyte. Now most of the Coulter or analyzers, they have reticulocyte channel. Now in this reticulocyte channel, this is for RBC, and as you find immature retic will be here. This is for platelet. Now this is the area which gives the fragmented red cell percentage. Now this is important because whenever you get FRC in your analyzer, it's a research parameter. You should always confirm it with the peripheral smear examination. Why? Because see, these are the one which is the cytoplasmic fragment. They don't have any fluorescence, so they will come towards this side. But they are larger than the platelet, smaller than the RBC, so will come in between. Now suppose if they are very small, what will happen? They will be counted as platelet. Suppose the patient is leukemic patient and there are cytoplasmic itself corresponds to about more than 2 schistocytes per hyperfield in light microscopy. And you should count at least 1000 RBCs in a well spread area to make percentage, and it is, if it is more than 1%, it is highly in favor of thrombotic microangiopathic hemolytic anemia. Now remember one thing, schistocytes, if it is associated with, see for example, it's a macrocytic anemia or megaloblastic anemia which is showing marked anisopoikilocytosis, then also you can see some schistocytes. But here the other changes in the moderate RBC changes should not be there. It's only the schistocytes which is an important feature. So then it in favor of microangiopathic hemolytic anemia. So there are 3 important causes. Hemolytic uremic syndrome classically has triad of microangiopathic hemolytic anemia with thrombocytopenia with acute renal failure. Now this is caused by Shiga toxin producing bacteria, Shigella or E. coli, and they cause these toxins, they bind to a receptor which is present on the glomerular endothelial cells, which causes inhibition of the protein synthesis and cell death. So that leads to endothelial injury. So that is a typical triad of HUS. Now, this presents generally with bloody diarrhea. Now, this is the atypical HUS, which is initially it was known as D negative or diarrhea negative, because they don't present with diarrhea, but they have complement mediated red cell destruction. Now, whenever there is a complement activation, there is also factors which inhibit the or control the complements or regulate the complements. So that is important factor is the factor H. So if the antibodies are directed against this factor H, that will lead to uncontrolled activation of the alternate pathway of complement and leading to acute kidney injury, which is a prominent feature. Again, the factor H can be abnormal, congenital or acquired. So it's important because in HUS generally we don't give any treatment, but here the plasma exchange and eculizumab, which is a complement inhibitor, can be given in these patients. The secondary HUS can happen with the autoimmunity, with transplantation or malignancy or any infection. Now, a word about TTP or thrombotic thrombocytopenic purpura. That's the third differential. Now, before going into that, just see this diagram. This shows a von Willebrand factor. Normally, it is secreted from the endothelial cells in a very large chain that is known as ultra-large multimer of von Willebrand factor, and over which the platelets are adhered. Now, there is an enzyme, which is the ADAMTS13, the scissor. This cleaves this von Willebrand factor. So that leads to help in the smaller chains of von Willebrand factors. So if it is not there, what will happen? A larger multimers are secreted, which will bind with the platelet. So that will lead to more thrombosis formation and thrombocytopenia. So these antibodies can be either directed against this ADAMTS13, or they can be antibodies which bind with this enzyme, and these complexes are then removed from the circulation. So this diagnosis of TTP requires the presence of decrease of ADAMTS13. Again, it can be congenital or acquired. They can be autoantibodies against this enzyme. The commonest, there are various causes, but the commonest is this drug which is used in the platelet inhibitor, and this is HIV infection which are associated with, or even in the COVID infection we have seen TTP. This is characterized by pentad. The fever, thrombocytopenia, MAHA, neurologic symptom and renal failure. Now remember one thing, this pentad is not always all five should be there. If you have only two features or maybe three features, then you can think of this diagnosis for confirmation. Now, in DIC, generally PT-APTT will be deranged much, but here the PT-APTT are usually remains normal. So in this patient, urine creatinine is raised. Urine showed RBCs and albumin 3+. So in view of the pentad, a diagnosis of TTP was suspected. So ADAMTS13 activity was 10% and ultrasound shows multiple large necrotic lymph nodes. So final diagnosis was TTP with disseminated tuberculosis was made. Plasma exchange, oral prednisolone and ATT was given, and he responded very well. Now important thing in this is ADAMTS13, which is nowadays it is available, but initially it was not available so frequently. And very important thing is you have to do pre-analytical variables are very important in the collection and processing of the ADAMTS13 samples, right? So that is how I think a few slides which were left are the lab findings which you find in these patients. So I'll just go through them to summarize that what you find when there is a extravascular hemolysis. When there is a extravascular hemolysis, yes, these are the two slides. Extravascular hemolysis, there are signs of increased red cell destruction. What happens? The hemoglobin is released. Now, the non-iron part of the heme is converted into biliverdin. Biliverdin is converted into bilirubin and carbon monoxide. Now, this is the only reaction in the body which produces carbon monoxide. So, it's very specific for destruction of red cells, whether in the vessel or in the bone marrow. So you can measure endogenous carbon monoxide, but this is a very tedious test, routinely not done. What you can measure is the indirect bilirubin. So that leads to jaundice in the patient, and if it is generally mild increase, if it is more than 5, then it is very unusual, a simple hemolytic anemia. Patient might be having associated liver pathology, like patient can be having a Crigler-Najjar syndrome, which leads to lack of conjugation. So, but hyperbilirubinemia is one investigation which you should do in these cases. The increased bilirubin lead to increased urobilinogen in the urine or stercobilinogen in the feces, which is again can be measured, but again not routinely done. Yes, urobilinogen you can measure. And increased LDH. LDH is present in the red cell. So once there lies, the LDH level will be increased, but this is not very specific because they are seen in other conditions also. In intravascular hemolysis, there is a slight different presentation. Now, what happens when the hemoglobin is released into the blood? It binds with heptoglobin. Now, this complex is destroyed in the liver. So what happens? The heptoglobin will be decreased. Now, this is a very sensitive test which can be done in intravascular hemolysis, but remember one thing, it is an acute phase reactant. So you have to do serial estimation of these heptoglobin. So, and if you find, for example, schistocytes and reduced heptoglobin, it is highly suggestive of intravascular hemolysis. Then it can also be passed into the urine as hemoglobinuria, or it can pass in the urine and absorbed in the proximal convoluted tubules. And then these are detached, they are passed into the urine, and you can check for hemosideruria by pulse reaction. So the test which you can do is hemoglobinemia. If the concentration is more than 50, you can measure by benzidine test. Or if it is more than 100, you can do simple sign methemoglobin test. So visibly the plasma will be red. Then you can measure hemoglobinuria by benzidine test, again hemosideruria by pulse reaction and heptoglobin. So these are the tests for intravascular hemolysis. So to conclude, you have to suspect hemolytic anemia, then you have to prove two things: increased destruction, whether intra or extravascular, and the bone marrow is responding to the destruction. Then according to the peripheral smear, see, peripheral smear is very important test which we generally don't see because of the automation, lot of automation, and a good peripheral smear is must. We have problem, suppose the slides are not good, then lot of spherocytes are seen, but if